Sir, can you hear me?
There is you are audible.
Yes, sir. Good afternoon, everybody. At the outset, I thank the organizing team for giving me an opportunity to demonstrate this case. This case is a 90 to 100 gram prostate.
Dheeraj, please ask the cameraman to focus you, man. You're missing.
Yes, sir.
Yeah.
This is a 65-year-old patient, sir, with a 90 gram prostate with acute retention of urine since the last 3 months. And I'm going to demonstrate a two-flap case. I'll be demonstrating my on-block technique with the sphincter saving technique and the early apical release. I'll be using a 22 French resectoscope for this case. If you can see here.
Yeah, can you kindly focus on the instruments, please?
You can see here, this is a 19 by 25 French resectoscope. There is a laser working element which goes in, and this lens is 2.9 mm lens, unlike the regular 4 mm lens which we use. And there's an extension that is connected here through which the laser fiber goes. So the unique thing about this instrument is, after I started using this instrument since the last 1 year, I never had to dilate the urethra. There's no visual operator required. And with the specially designed tip, I can directly go inside the urethra in first go.
Dr. Dheeraj is 22 French, right?
Yes, sir. Yes, sir.
Great. Dr. Dheeraj, even before you start, we are all like to appreciate and congratulate you because you youngsters are going to be the future.
That's what.
Great.
Thank you, sir. I thank the organizers also for giving me an opportunity.
He the only person now is doing enucleation with the 22 French.
Fantastic, sir. That is great, sir.
How the laser
is great. I think they have to be encouraged over a period of time.
In most of the centers, they are using 24 or 26 French resectoscope for enucleation. Even in most of the centers where they are doing any number of
light can be
polyps. But he has been doing this with almost 1 to 2 years. Miniscope, 22 French.
Excellent. Okay. So I like this early release technique, which I call it the inverted shape incision, which I give. So before doing that, I always empty my bladder first. I always tend to empty the bladder before I give my initial marking incisions. Right, can we? This is the IPG 60 watt laser which I am using, but routinely I use the 35 watt machine which I have. Even for the bigger prostate, I tend to use my 35 watt machine only. I use the energy setting of 35 hertz and 1 watt of energy.
Dr. Dheeraj, we will have an opportunity to see the prostate, how it looks like even before you start.
Mohan, can you show the laser?
Looks like a lengthy gland.
Good job. So my regular setting would be the 1 watt of energy and the 35 hertz of frequency, which I normally use. And I don't use a separate coagulation mechanism. I just come back a little if at all there is any hemostasis required, and I use the same application for hemostasis as well. So now I'll be starting the procedure. You can see here, this is the posterior part of the urethra. You can appreciate the wrinkle of the sphincter here or here. This is the verumontanum. This is the only landmark which we have in the beginning. So right at the above it, at the 12 o'clock region, I tend to take the initial marking. I take a marking from the 11 o'clock to the 1 o'clock region. This will be my landmark for the rest of the procedure. This is the verumontanum. What I do is, after taking this initial mark at 12 o'clock region, I develop the posterior plane. First, I'll give longitudinal incisions on either side of the verumontanum. After giving the initial mucosal incision, I gently use the beak of my resectoscope and I tend to develop the plane here. You can appreciate here the capsule. This would be the capsule and this would be the adenoma. So this will be replicated on the opposite side as well. This is the verumontanum here. You can see the groove, a given longitudinal incision over here, mucosal incision, and deepen it a little bit.
Can the second camera, rather than showing only the machine settings, show your hand movements?
Once I think I'm deep enough, and I use the beak of the resectoscope here again, and try to find the capsular plane.
Looks to be a pretty juicy gland straight away. Does it make any difference to your procedure?
Sir, I couldn't hear you properly.
No, looks to be a little juicy gland straight away. When we do a classical tree or P, we find it difficult in a juicy gland.
Yes,
But,
sir,
does it
that is
make
my
any-
initial impression, sir. Yes.
Does it make any difference when you do this procedure?
There are three types of capsules when we see, sir. The one you just mentioned, the capsule is usually smooth in some other cases, where the cases tends to be a little easy for dissection, mechanical dissection. And there are other glands where the capsule here is soft, or sometimes it's highly vascular when it becomes more difficult. Especially in cases like chronic prostatitis, we are not able to find the plane so easily. So this is the posterior plane on one side, and on this gland, I'm finding it a little difficult to find the right plane. Little patience. There are little adhesions over here, which I'll break with the laser energy. Once I break these adhesions, probably I'll find a better plane. This is a better plane here. This is the capsule which is nicely appreciated. And this capsule can be identified that's by the smooth glistening nature of the capsule, and also you can see the vessels here running parallel to the capsule here. All these vessels.
Dr. Dheeraj, can you show us the capsule and how you differentiate it from the rest?
So if you can see here, sir, this is the smooth glistening layer, and also you can see the blood vessels running parallelly over the capsule here, whereas this is the adenoma. If you burn here, you can see a lot of charring happening. This is the prostate lobe here, and this would be the capsule.
Good, that's good. Yeah.
So what I'll be doing is I'll be joining both the planes. The verumontanum here, I've developed the capsule on either side of the verumontanum. Now what I'm going to do is I'm connecting both the planes here. Since I'm doing an en bloc technique, not the 3-lobe or the 2-lobe technique, connecting these planes would be important. This is one area where probably I'll use more of laser energy. Once I think I've deepened this incision a bit, I'm again going to use the mechanical energy as well here. Any adhesions or any bleeding, I'm going to use the laser energy. I'm going to do more of mechanical rather than the photomechanical effect. This is called the truly anatomical enucleation rather than the vapor enucleation, where we use more of laser energy rather than the mechanical effect. So after developing this posterior plane, what we'll do is we will give the inverted V-shape incision. If you can see here, this mucosal wing has been raised. By lifting this posterior, developing this posterior plane and dissecting this apical gland on both the sides, now what we have done is we have raised the apical flaps on both the sides. You can see here, what I'll do is I'll give an inverted V-shape incision. I'll join the previous 12 o'clock incision which I have made, and maintaining, appreciating the concavity of the lateral lobes, I'm going to give an incision from the 12 o'clock in an inverted V fashion. This is onto the patient's left lobe, and this incision would be onto the patient's right lobe.
People inside, I'm seeing all of you are looking at the left side of the screen, but the most important thing is the right side of the screen, how he is manipulating. We are all missing it.
Since many of us are right-handers, developing a plane on the patient's left lobe is easier. This will be more of a backhand for the right-hander. So developing a plane on the patient's right lobe is much more difficult. So what we do is, once we give this V-shape incision, essentially what we are trying to do is we are trying to separate this mucosa here, which will lie over the external sphincter, which I believe is the most important part of this procedure to prevent any stress incontinence, early stress incontinence. So once this incision is given, it is deepened further. It's all about planes. Anatomical enucleation is all about planes. Now we have developed a posterior plane here. Now what we are going to do is, we are going to, I think there's a small prostatic abscess cavity which I have broken. Essentially what I'm trying to do is, I'm deepening the incision here. And I'm trying to separate the mucosa, the ventral mucosa, from the apical part of the adenoma. This is the apical part of the adenoma being dissected away from the ventral mucosa. You can see the capsule here nicely again. We can find an anterior plane also here, the apical part of the prostate. Just like we developed a posterior plane on the left lobe, now I'm trying to develop an anterior plane on the patient's left lobe. It's a nice plane which I'm able to get in this patient by separating the prostatic apex from the ventral mucosa. You can see here the ventral mucosa here is completely detached from the prostatic apical lobe. Similar procedure, a similar thing will be repeated on the patient's right lobe as well. I feel the biggest advantage in thulium fiber laser is that we can nicely see the charring effect of the prostate gland, unlike the holmium laser, where everything would be more in a whitish manner rather than a yellow color, which you can appreciate on the prostate gland here. I feel we can use that to our advantage and we can identify exactly where we are going. Again, I further dissect the plane, the posterior level here. This is at the 6 o'clock position, the median lobe. Whenever there are adhesions, I always use this laser energy. And wherever I need to find the plane, I just give a gentle push with the hands, produce that mechanical effect and develop a good anatomical plane between the gland and the capsule. This is the dissection of the right lobe from the 6 o'clock to the 12 o'clock region. You can see here, it's almost like a bloodless plane. You are in the stay on the capsule. At the same time, always keep coming back and see if the ventral mucosa is completely detached. You can see here the ventral mucosa on the patient's right lobe is still attached. So we have to deepen the incision which we have taken initially, the inverted V-shape incision. The idea of this procedure, the sphincter saving technique, is to release the ventral mucosa much early. This is very important in maintaining. Yeah, this is the ventral mucosa here over the roof between the 11 o'clock and the 1 o'clock position. We try to preserve as much of mucosa as possible in order to prevent any early stress incontinence. Holds better. It looked initially like a pretty much vascular gland, and I'm having to use a lot of irrigation actually to maintain good planes. But you can see the very good hemostatic effect of this thulium fiber laser. So this would be the posterior plane. Now I have developed this plane anteriorly from the 6 o'clock to the 12 o'clock position. And if you can see, this is the final part of the apical gland being detached from this ventral mucosa, which is overlying the sphincter. This is the final part of the apex being dissected. So this is the most crucial part of this surgery, so that we preserve this, we don't stretch the external sphincter and preserve as much of mucosa as possible, at the same time not leaving any of the prostatic tissue. So we're almost reaching the 12 o'clock region. If you can see now, I'm connecting both the lobes. Just like I connected both the right lobe and the left lobe on the posterior plane, now I'm connecting both lobes on the anterior plane as well. So this is the patient's left lobe here, and I'm connecting both the planes here at the 12 o'clock region. So once this is done, you can see here this mucosa, which is overlaying the sphincter, is completely detached. So whatever I do with this lobe, it's not going to cause any kind of stretch on this external sphincter fibers, striated sphincter. So I'm very confident that I'll not be able to do any harm with regards to the continence mechanism post-operatively. A little bit of adhesions here on the patient's left lobe. Well, I'm having to use a little more of laser energy than what I'm used to. The other thing about this laser is I don't use a contact mode in this laser, unlike the thulium YAG laser. This is a thulium fiber laser. We get a very good dissection property with this laser. I'm not using the contact mode. If you can see, I'm staying a few millimeters away from the tissue and I'm firing the laser, which creates a bubble, just like the holmium laser, and it is used for a good dissection. I'm not using this contact mode at all. The area where I had a little adhesions previously, but I am able to overcome it. The good thing about en bloc enucleation is that if at all you lose a plane on one lobe, you can always dissect on the opposite lobe and always come back to see where you had difficulty. You can always skip the step to a later part. If I'm having any difficulty in dissecting this part, what you can do is you can go to the opposite side. You can go to the opposite side, you can do some dissection, always join the plane to the area where you are having difficulty as well. That's a good thing about en bloc enucleation.
We are so
En bloc, en
absorbed.
bloc, sir.
Yeah, we are so absorbed into your surgery that nobody is going to ask you any questions at this stage.
I'd love to take any questions, sir, if there are any.
No, everybody is absorbed into the surgery. There is only thing we'd like to know is, as you develop this technique over a period of time, what are the problems or difficulties which you encountered actually during these dissections? I'm not supposed to ask you this question. Everything is going fine for you.
Sir, I'm not able to hear you properly.
Then what are the difficulties which you have encountered while learning?
The biggest challenge, sir, the difficulties for this technique, the biggest challenge for me would be two things, sir. Apart, if you are able to overcome the learning curve, it is good. It takes a lot of time for you to master this procedure. It takes a huge learning curve to be able to deliver a good result. The main challenges I feel is the stricture and also the stress incontinence which we have after this procedure. So after using this 22 French resectoscope, I feel the stricture rate would come down a great deal. I've used it for an year and I'm seeing good results with that. And also the stress incontinence is one thing where we are scared of. Sir. So that part is usually dealt if we have this early apical release, if you are able to do, and we are able to preserve this mucosa here. If you can see here this mucosa nicely, then there will be the early coaptation of urethra, and you are able to avoid any stress incontinence immediate post-operative. I think with the excellent hemostatic properties of these lasers, I don't think bleeding is much of an issue once you are beyond the learning curve.
And what about post-operative irritative complaints of the patient?
Sir, come again, sir. Post-operative
Post-operative irritative complaints to the patients following the laser enucleation.
irritation. Post-op dysuria, which you mean, sir?
Dysuria, exactly.
So post-operative dysuria we used to see previously, sir, because we used to go through the gland. What we used to do is, if we didn't find the right planes, we used to go through the gland. In that way, what we are doing is we are leaving much of the prostatic tissue behind. What will happen is it will get necrosed after a bit and it will cause a lot of dysuric symptoms. But now, if you can see here, sir, I'm staying right on the capsule. I'm not leaving any prostatic tissue behind. If you are able to maintain this, these kind of planes, we don't see any dysuria.
That's great.
I normally remove the catheters within 24 or 48 hours, and patients don't complain of much, dysuria or any pain, such kind of things. It won't be there. Earlier in my learning curve, when I was using lot of energy, you can see here even big glands, I'm using only 35 watts of energy, and whenever there's a possibility, I'm using mechanical force just like this. So if you do this, you're not using much energy. Only if you're using more energy, that is the time where you'll get to char a lot of prostate tissue, and if you're leaving behind a lot of prostate tissue, that is the time when you will have these dysuric symptoms. So I think this is this posterior part of the dissection and the lateral part is done. I'll be going from the 1 o'clock to the 11 o'clock position now. Initially, it looked like a very small gland, but if you can see here, the lateral lobes, there are huge lateral lobes here. I'm having to dissect, work upon. This is the dissection between the 11 o'clock and the 1 o'clock region here. The other thing is, in the initial learning curve, we tend to lift the prostate from the 6 o'clock to the 12 o'clock position, but it tends to leave you with a lot of perforations. What I would do is I would like to go on top of the prostate and then bring the prostate downwards, just like this. You can see here, I'm going on top of the prostate and bringing the dissection downwards. That is when you will have less perforations.
Good. That's what actually we were looking. You have never lifted the prostate from below right from the beginning. Good. Dheeraj, the expert is here. Dr. Malik sir has joined us here.
Hello, sir.
He is giving a hello to you off the mic.
So I can safely say that even in the anterior plane, both the lobes have been connected. Right now, if you can see, I have control all round. This would be just for an orientation. This would be the verumontanum. This is the posterior plane here. The adenoma is above and the capsule is below. And I have a control over the lateral aspect as well. And this is the roof, the anterior plane. And if you can see here, this is the lateral part of the patient's right lobe. So I have control all around the prostate. So because my early apical dissection has already been done, I can use a lot of mechanical pressure here rather than the laser energy. Whenever you give this mechanical push, there will be some bleeders which you will have to come back and always take care of these bleeders. And if you have noticed, I have not used a separate setting for this hemostasis. I just come back and activate the laser from a little behind. If you can see here, I'm not using the contact mode, but I'm coming a little distance away and I'm operating this laser and producing that photomechanical effect to secure a good hemostasis. Yeah.
This is the continuous flow irrigation. Dr.
Yes, sir.
Dheeraj.
This is a continuous flow.
How good it is in 22 size, Dr. Dheeraj?
If you can see here, the vision is fairly
Vision
good,
is
sir.
fairly good in spite of the 22.
I am not feeling any difficulty with whatever irrigation I'm having. But I'm not sure whether the same effect would be there for a 3-lobe or the 2-lobe technique, because I'm working in a closed space here. Because I'm doing the total 1-lobe technique, the unblock technique, everything is closed here. I'm working in a very tight space. So whatever irrigation this 22 French resectoscope is offering me, that is actually good enough for me. But if I'm doing a 2-lobe or a 3-lobe, I don't know whether the same kind of effect would be there or what. So if you can see here, sir, you can see the transparent layer here, the vertical fibers, that would be the bladder neck fibers. So once I identify these bladder neck fibers, I would take these bladder neck fibers down, and I have a new landmark here. Until now, I only had that verumontanum posterior and anterior planes. Now I have a whole different landmarks also. I have the bladder neck also to work upon. So this will be my landmark. Unlike the traditional enucleation surgeons, where the dissection used to be from the 6 o'clock to the 12 o'clock position, this en-bloc technique, what it does is we can take the dissection from the 12 o'clock downwards to the 6 o'clock. This is how we avoid more of the perforations. As you all know, the bladder neck area, the bleeding would be more than what we see in the other parts of the prostate, where the vessels tend to be much bigger. And the same dissection, I'm taking it to the opposite side as well. I'm completely opening up the bladder neck. All these big vessels here, they can be nicely tackled with this very good hemostatic effect of this thulium fiber laser. And I keep reminding you, I'm only using the 35 watts of energy, which I normally do. Even though this is 60 watts of energy, I'm very comfortable with using this 35 watts of energy.
And this gives both your cutting as well as coagulation.
Yes, sir. Yes, sir. I don't use a separate pedal for a hemostasis or anything. I just come back a little bit and coagulate the vessels. So once this bladder neck is completely opened up, the only part remaining for us would be the posterior dissection, proximally. I've separated the apical part of the prostate. I've done the lateral dissection. I've opened up the bladder neck from the roof. So the only step would be for me would be to take the dissection from the distal part of the prostate to the proximal part. All this can be done mechanically. All this can be done mechanically. For my usual standard, I'm using more of laser energy just for demonstration, but I use more of mechanical effect rather than the laser energy. Since many people are not doing this procedure, I'd like to take the questions from somebody rather than me telling, sir.
Absolutely. I think youngsters can ask questions. We have Dr. Malik sir also here to answer.
No. Dheeraj, very nice work, no doubt about it. I just reminded of our publication on bipolar enucleation, which is the similar techniques but without a thulium. I think you started believing that mechanical energy is adequate. We don't need a laser to do a real enucleation. Am I right?
Exactly, sir. I watched your CD, that Art of Enucleation CD, for a lot of times, sir. That is been one of my inspiration to do more of
No, yeah,
mechanical.
Jeff's replicated it, but only one thing which we did at that point of time is left this attachment just in front of the verumontanum,
Yes, sir.
so that we can resect. But later we enucleated it and did a morcellation later too.
Yes, sir.
But wonderful, it's very nicely done, and I can see those. See, one of the things what you need to show that is how do you know that you are in the correct plane? You see that vessels arborization. You see vessels going on the wall of the thing. You can show that
These are the
on the wall. On the wall. This is at least in the bladder neck.
Yeah.
This is the 4 o'clock vessel of the bladder neck. But if you see onto the lateral part of the capsule, you see the arborization of the vessels, a serpentine arborization of the vessels. That is a true plane where you can say that I am in the enucleation plane. Wonderful. These arborizations here.
Yeah,
Those things,
these are the things.
These are
They are the things. These are the vessels which are running very parallel to the bladder. So the entire prostate here is separated on the anterior plane, the lateral sides, even the apical part is completely separated. And I will again show you the verumontanum here, and also I'll show you the ventral mucosa, which is very nicely preserved.
Perfect.
This is very essential.
Very essential. That's possibly, and you see that the anterior part, until the dorsally, you see that the mucosa is more ventrally. This is a 30-degree lens, but still you'll be able to see that there is that part of the mucosa is more preserved, because that is a main reason for stress incontinence. Because we keep a circle on the level of verumontanum, but the circle should be a little tangential, going a little towards cephalad in the dorsal part of it.
Correct. And also, I think this smaller size instruments prevents the shearing of the urethral mucosa.
More than that, your experience. That matters.
Yes.
The more you become experienced, the lesser the sharing on the mucosa, lesser the stress incontinence, everything will become less.
Yes, sir.
You will have a much more articulated movements rather than doubtful movements. That is the reason for more of a stress on the sphincter area.
Yes, sir. And our operating time also will come down a lot.
Perfectly executed. Congratulations. I think your dad's advice of becoming anatomical has helped you a lot.
Yes, sir. Yes, sir.
I saw your enucleation beforehand, but that was different, and this is different.
I used to use more of laser energy. Now I'm using more of mechanical.
Yes, exactly. I see that.
The final part of the posterior aspect of the gland, and also a little bit of lateral attachment of the patient right lobe. I always try to bring the dissection from above downwards and from lateral to medial, rather than lifting the gland like this upwards, where we tend to perforate a lot.
That's a most common reason for a retrotrigonization. You just end up in going behind the trigone.
Correct. Always take the dissection from lateral to the medial and from above downwards.
Reason for that is the trigonal muscle is very thick, and it continues right up to the verumontanum. So if you don't divide that properly much earlier, you end up in going behind the behind the trigonal muscle.
Yes, sir. That is one more reason why I'm using more of laser energy here. Unlike previously where I used more of mechanical effect. Now I'm trying to use the photomechanical.
Perfectly, because the more you do a mechanical, you end up in lifting the trigone rather than cutting the trigone.
Correct. Can you get the morcellate ready also? And also can. There is a lot of worry about ureteric orifice being involved. Initially, it's a good idea to always keep a watch on the ureteric orifices, but once we delineate the bladder neck fibers nicely, you hardly can injure the ureteric orifice.
The chance of injury of ureters are much less in enucleation than TURP. It's very less.
Sir was asking about how do you differentiate between the prostate and the capsule. If you can see here, sir, the capsule is not that yellowish in color. It's more glistening. Whereas if you use energy on this prostate, it will char more. That's a beauty about this thulium fiber laser, like the holmium laser, where everything looks white if you are lost in a plane, and if you lose a plane in a thulium fiber laser or a thulium YAG laser, probably it comes to an advantage. The charring actually comes to an advantage. More charring occurs if you actually use the contact mode, but like you have noticed, I use the non-contact mode. You can see that there's not much charring like people always talk.
No, that's because you have used more mechanical force.
More mechanical.
That's exactly. You used less amount of
Yes.
laser. That's the reason why the carbonization doesn't happen.
Yes, sir.
But
So,
the majority of your this thing has been done on a mechanical aspect.
yes.
Then that's the reason why.
Yes. So I'm done with the enucleation. Everything has been
Wonderful. Perfect.
removed and blocked.
Perfect.
So
Perfect. Wow.
this you can see the contour of the prostate has been nicely maintained. The ventral mucosa also is preserved nicely.
What's your opinion on making multiple incisions on that to make your morcellation easier at this point of time?
Not required, sir.
Not required?
I hardly had to use this incision, sir. To be frank, in my personal experience, at least, I have not have had to use this. I routinely use a wolf piranha morcellator, which I didn't find much of a difference.
Once you
It's more
control this,
more than the morcellator. It is the way the gland. Sometimes some nodules will be there. They never get sucked into that gap. That's a problem.
I mean, the slower the suction we use, I think the better there is efficiently we can able to morcellate the tissue better. That's what I feel.
Exactly.
We try to do
Exactly.
it more fast. That's the time when the gland gets slipped away.
Yes.
There will be glands where we have a smooth contour, and then we'll probably have to use a lower speed setting for the suction.
Exactly. The faster it is, the tendency of it not sticking onto the tip is more likely.
The other thing is we need to check on the blades also, sir, whether it's an old blade, new blade. It also might matter a bit.
Oh, sure, definitely.
once you control the speeding, we would like to see the fossa.
It's very essential to get a good hemostasis, sir, because once we start our morcellation, not for this case, but initially in the beginning cases, we are already tired doing this long duration of enucleation, and there will be lapse of concentration, and that's when we get all these bladder injuries during morcellation. So we should spend some extra time for the hemostasis before we progress to morcellate. So this would be the verumontanum, and just like I've shown, this is the ventral mucosa. This is the fossa here.
Right. When do you say I'll morcellate?
Sir?
When do you say your hemostasis is good enough to assess? I tell you why I'm asking this question.
Yes,
What looks very nice when you're doing this sort of a job with a continuous irrigation suddenly becomes a little bloody when you put a morcellator in. Am I right?
Yes, sir.
So when do you say, okay, I'm done with it, I'll morcellate now?
Whenever there is any doubt, sir, there's a little bit of tissue left here. I'm going to take it out now. But whenever there is a little doubt, I tend to empty the bladder and always check again.
Okay.
Because the bladder is full now, we might miss some bleeders which are coming from the bladder neck.
That's exactly.
So what I do is, if there is a little doubt, I empty the bladder, check the bladder neck thoroughly, and only then, and I'll progress towards morcellation.
So you empty the bladder, see the return, and then decide.
Yes, sir. Yes.
Never see the thing what happens when the sheath is inside.
No, nothing. We need to check the BP of the blood pressures of the patient also, because there will be a little hypotension sometimes, and we might miss some small bleeders which might trouble you later on.
Oh, this is one more gland. What is this?
This is a small part of which is left in the roof, sir. So
No. There's one more screen coming up. I was wondering both are looking alike, and how come the prostate is still in situ? That's the next case on the other table. I'm sorry.
Camera crew, can we quickly move to the other side and come back?
Yes.
Dheeraj will be back with you.
Sure,
He'll
sir,
be back
sure.
with you. Yeah.
How much time we took? Time and what in? Total.
Saif is doing, I think.
Looks like Taif, sir.
Hmm.
Dr. Taif?
Sir, good evening, sir.
Good evening, Dr. Taif. Dr. Chengalvarayan here. You are with Dr. Malik, sir, Dr. Alisha, and as well as Dr. Vidyasagar.
Needs to focus your.
The large grade 3 trilobar gland that has been given. So the plan is for a whole up. Have two options to handle this.
Can you focus it?
Focus. But
Yeah,
Better
that's
now?
better. That's better. Better.
the initial cystoscopy, this is the area of the sphincter. Veru.
Can you
The
unzoom
gland-
it? It is a little
Patient BP.
still. Yeah, that's
No,
better. I
okay.
think that will be better.
Okay. So have the arrow at the 12 o'clock. This would be an important landmark during the procedure to identify where I would be handling. It would be exactly opposite to the fiber. So whenever I rotate, you can have an orientation. So this is the large median lobe that we have, and the ureteric orifices are here. So this is the veru. The lateral lobe seems to extend up till here. This is the extension of the lateral lobes beyond the level of the veru. So here we would have to be extra cautious while lifting the apical adenoma. So when we are proceeding with this kind of a gland, so we would have an option to go either an en block, getting it entire thing as a single lobe, or if we can make it as a trilobar. So since this is a large median lobe, we have an option of taking off the median lobe first and then the two lobes individually also. So for now I'm starting with the en block technique. So the settings is 1.8 joule and 45. No issues, that is okay. Yes, coagulation setting is 0.635. So we are using a Quanta Cyber machine and 550 fiber. Can you start? So the
Taif,
advantage of this device is we have two separate pedals, one for cutting and one for coagulation. For coagulation, we have an option of either stepping back a bit with the fiber and defocusing, or we can use the low energy from the left pedal to coagulate it.
Dr. Taif, maybe have a suggestion from here.
Yes, sir.
Because we are seeing an enucleation en bloc on the other side.
Okay.
Is it okay for you to take
You
off the
want to
median
see-
lobe first and then show how we remove the lateral
You
lobes?
would like to see a trilobar?
Exactly.
Okay, fine. That is also okay.
Is it okay with the audience? Because we are seeing an en bloc on the other side. Yeah.
Fine. So if we are proceeding with en block, the steps would be similar. So make a groove here on either side of the verumontanum. This groove is the area where the adenoma fuses with the urethral mucosa. So this is the gutter where it is the shallowest. The surgical plane and the urethral mucosal lumen, the gap is the least. So this is the earliest part where you can enter the plane. So this is where you would have made the marks, connected it on either sides, and proceeded from distally towards the proximal thing. So when we are going for a trilobar thing, we make grooves here. So one at 5 and 7. So this would deepen till the bladder neck and then separate it out from the veru. So we'll proceed first with the 5 o'clock groove. So our proximal landmark would be the ureteric orifice. Fair enough. So we start here. Is it on? Okay.
We want to know the laser settings.
Laser
please.
settings. Hold it. 1.5 into 45, right?
Yes, sir. 1.8, 45.
1.8, 45.
So while the advantage of holmium laser is that it separates the fibers without fusing it, at the same time, it acts as a slight disadvantage in regards to the coagulation thing, wherein it would separate the blood vessel. and you would not get a complete fusion kind of a effect as compared to the thulium fiber. Whether the vision is good enough there, or I need to focus a bit more?
No, vision is okay. It's bloody now. You need to focus possibly. Focus a little.
So we would have to find our plane between the two lobes. So many a times it would be an artificial plane because of the fusion of the two lobes. And this is where we would feel that we are cutting through the gland.
Small announcement, please. Today's dinner is at Prakriti Convention Center. Is very nearer to Leonia Resorts. Also, the council meeting is also at the same venue. Thank you.
Progress will happen. Said council meeting on drinks. This will happen. Then you focus a little bit. Yeah, better now.
So once we make the groove, rather than a small incision, we widen the groove a bit so that the separation happens better, because eventually we will have to use the grooves on either side. So we come back, see, this is the distal limit. So this is the plane, the surgical plane where it separates easily, and this is the arborization of vessels that was being discussed. So irrespective of what modality we use, the principle of procedure would be the same to achieve this plane and proceed along with it.
Yeah, you're a little faster. I think we are not able to comprehend. A little slower, please.
So this is 5 o'clock groove. I'm deepening. If we can appreciate, there is no fusion of the fibers. You can see each individual fiber being separated as it is. You can appreciate the anatomy to the fullest. You can have control of which fiber you are wanting to buzz and which fiber you are wanting to cut. So this is the first step now to the Veru, and this is the 5 o'clock groove that we have made. So we would repeat the similar procedure at 7 o'clock. The probable area.
Tommy. Umia, Tommy.
Going between the 5 and 7 o'clock will separate the median lobe from the lateral lobe. So again deepening it.
Full
Find the major
full
bleeders here.
We want full. Bladder injury.
Never know which side
Sir,
would
can
be
you
the
hear me, sir?
actual cleavage between the adenomas. So in between you might have to cut through the nodules. That does not mean that you would be behind any of those.
Can you do that hemostasis type? I think it's a little bloody for us to see.
2 minutes now. Grams.
Quite a vascular.
Quite vascular. I think you need that vessel. One vessel is there which need to be taken.
As long as the bladder is full.
Maybe I'll just separate the lobe, and the traction on the vessel would be relatively less, and then probably I can do the hemostasis better.
Sir, can you hear me,
So
sir?
the stretch is not allowing it to coapt.
Yeah, go ahead. Go, Taif, you'll just go to the next theater and come back.
I'm just showing the morcellation, sir.
Yeah, I've seen. We are seeing it on the other screen. Yeah.
Almost done with it. So I wanted to add a comment on the Biored morcellator I'm using. 3 steps, sir. If I press the initially, if I press it lightly, this prostate will come and catch hold of the morcellator. If I press it at the second level, it will morcellate slowly.
Yeah.
If I press it hard, it will morcellate fast, suck fastly.
Good. No, I heard because Arun was using and he was telling that it was quite good because suction and the machine both are integrated.
Yes, sir. Anything which is rotating and integrated, that should be fine, sir. Whatever the model.
It's
rotatable blades with an integrated system. It is. I believe it's more safe.
I don't know whether how far it is. It's nothing but Hawk one, that Chinese one. Is this the same thing what they are marketing? I don't know. They said that it appears to be so because they have a similar system.
Yes. I always in my normal routine practice use an ultrasound also. One of my OT assistants will be holding a probe.
What makes a difference by having an ultrasound or not having an ultrasound?
We are more comfortable, sir. We are more comfortable.
What, seeing what? The
I'm
bladder or the ultrasound?
Sir, 70% of the times I'd be seeing my ultrasound screen rather than the
That's
monitor.
exactly what I was asking you. It's majority of the times once we have an ultrasound, we'll be looking at ultrasound rather than the inside. That's is it correct or not? I don't know, but
the monitor will probably occasionally see whether the tissue is actually being held by the morcellator blade. But otherwise, I'd prefer seeing ultrasound, especially in a case which has bled a lot, or especially in cases where there is a compromised bladder. Low capacity bladder is where this ultrasound comes very handy.
I can understand. That's a low capacity bladders. Definitely, it's very handy. But
it's a luxury, sir. It's not a compulsion. Definitely, it's a luxury, I feel.
It's a super luxury. Having a morcellator itself is a luxury. Ultrasound guided morcellator is the next level of luxury. It's good.
The final part getting the other advantage of this en bloc is that we don't need to morcellate it separately. Everything comes once. Instead of giving more incisions, unlike the 2-lobe and the 3-lobe technique, I feel en bloc we can do a pretty swift job. The 90-gram prostate, I was just told we have done it in about less than 40 minutes, I believe.
I think whether to do an unblock or a 3-lobe or a bilobe is an individual situation dependent rather than what is good at. I think possibly in some situations an unblock is good, and some situations a trilobar is good, and sometimes you have hardly any tissue in the posterior aspect, which makes you to do a bilobar enucleation, something like that. So unblock makes, as you get more experience, you make it unblock so that you can do it off in a very short time.
Yes.
What a vessel, boss. A vessel. Huh? A huge median lobe, right? So the vessels also should be big. Lot of the times, the movement, as Taif was telling, that's a correct point. In any of these things, you enucleate the lobe and leave it alone, and if the stretch on the capsule less, the bleeding settles. Stretch on the capsule is more, the bleeding will be more. So if it is getting retracted like that, you better do the enucleation first and then look for it.
Malik sir, what about the movements of Dr. Taif? Is it more of a mechanical movement or it's more of an
No, he's still
laser kind of?
it's both. It's both. And in fact, I could see Dheeraj doing 80% of it is mechanical and 20% is with laser, whereas 60% is laser and 60% is mechanical and it depends. You see, there's some glands it just goes, it opens up without any problem, and there's hardly any bleeding. There's some glands it doesn't open. There will be much amount of tissue in between. So it depends.
It's not depending on which lobe it is, like median lobe
I
or
think
no.
no. Sometimes there will be a lot of this cleavage. If there is a little prostatitis and a lot of adhesion, you end up in using more laser or any other energy, whatever you do. I was using a bipolar before, and so. That's, they have that frustration because they were supposed to show in the pre-lunch tea session. And you have allowed them to show post-lunch tea session.
Sir,
So they can't show the frustration on you, so they're showing it on the prostate.
Done with the procedure, sir. I'll be leaving a catheter for 2 days in this procedure.
Thank you, Dr. Dheeraj. That was wonderful. I think we can have a big clap for
We
Dr.
can
Dheeraj.
see the flow here, sir. If you can see the flow here, if you can appreciate it. So the wide fossa, flow you can appreciate.
They are not able to, yeah.
the camera. Wonderful, very nice. No, you used, I saw you using a 22 French scope for enucleation, and
Yes.
you used a 26 scope for morcellation. Am I right?
Correct, sir, correct. But whenever there is a very tight urethra, as we were speaking before, the ultrasound, how it helps. I don't use the 26 French outer sheath. I directly put the nephroscope and I morcellate it, sir. That's an advantage if you have an ultrasound. Because the bladder tends to drain out quickly when we can't introduce the 26 French. To prevent the strictures, I use the ultrasound as a guide and I use the nephroscope.
Nephroscope is a Star's nephroscope, doesn't have a, the thing comes out. It doesn't come inside, right? It comes outside the nephroscope. So you pass it as a...
I use the Wolf nephroscope, sir. Half moon nephroscope, Wolf use it. But there is a nephroscope morcelloscope which is coming in RZ company. Right now it's not available in India, but they have developed this morcelloscope which goes through this 22 French resectoscope.
But the size of the probe will be smaller. It takes more time. The bigger the gland, it's going to take more time. Am I right?
Could be, sir. Could be.
Obviously, you can't have the same size of a probe going through a smaller scope.
We'll have to see, sir. Once it comes, we'll have to see.
The biggest negative point of any of these things is the size of the scope. The bigger the scope, the higher the chance possibly of logically being for a stricture. Taif has done his median lobe. Am I right, Taif? Can you connect to the Taif theta? Dheeraj, wonderful job. Again, congratulations.
Thank you, sir.
Marvelous.
Once again, I take this opportunity to thank the SOGAS organizing team and scientific committee for giving me.
Wonderful. Dr. Taif?
Sir, that's the median lobe.